I really appreciate the opportunity and the invitation again to your Canadian support group. This is it's a privilege each time I've come up with, whether it was Winnipeg or Toronto a year ago and now Toronto today, simply because I really feel that the Canadian Society bridges so beautifully the European expertise and hopefully the United States expertise. I felt just a wee bit bad, and again I want to thank Ms. Coleman and Jim Cormus for the invitation. I felt a little bit bad though when Ms. Coleman was introducing, pardon? Maureen, yeah, okay, thank you. Maureen, I feel badly when Maureen was speaking this morning about our European friends and colleagues that came all the way over from Europe, and I didn't think about it until I added up the number of hours it took me to go from Iowa City by way of Chicago here. It turned out to be 8 hours and 30 minutes from door to door. And I stayed at the American Airlines gate because they kept saying it was going to be taking off, and then it was delayed. And there were 6 flights that came in and out from that same gate. And right across from that hallway was a McDonald's. And it's incredible. I don't know if it's the people that fly American Airlines or not, but they all have this want for chicken McNuggets. This is an absolute true story. There was one flight where I was surrounded by 5 people eating chicken McNuggets. I think if I see a chicken McNugget, I might have a psychotic episode right on the spot. I must tell you. My charge today, and I really appreciate the way it's been broken down and what we've heard already. I mean, this has been wonderful, and like they say in classical Latin, repetitio est mater studendum. Repetition is the mother of learning. And what I'm going to try and share in the first part of this talk, as we think in terms of an algorithm of care or a pathway of care or a team approach, and you'll see on your handouts the schema that we've used for 15 years at our program. And it's pretty much what everybody has been saying, the multidisciplined approach. And we'll break out each of the boxes as we go forward, starting with the pathology and the radioimmunoassay boxes. And we'll come to that. But what I hope to do today, I always need to share a little bit of the rich history involving neuroendocrine tumors, and to at least talk a little bit about some of the anatomy and maybe the gardens where these neuroendocrine tumors either begin to grow or come to reside, such as the liver and primary in the lung, to appreciate perhaps why things behave the way they do. We'll touch again on some pathology briefly. That was well done by Dr. Singh. And I'd like to share some of the caveats maybe of the radioimmunoassays and how we can use them as we go forward in the process of therapy. So really, Foregut was the first to describe the cell that I'll show you a picture in a moment. Friedrich Foregut was an Austrian morphologist, anatomist. And amongst the things that he described, not knowing the physiology, was the in 1938 and 34 was the neuroendocrine cell, which he called Helitzelin, which means clear cell. And you can see from every place in the room that you're talking about a nucleus, a rich blue nucleus, surrounded by a very rich Golgi apparatus that helps to form and make the peptides that these unique cells that exist normally in our body in different areas reside and function as. And what we're talking about with neuroendocrine tumors is just very much too much of a good cell, if you will. And if the hormone that they make is important, then it becomes a syndrome. It becomes very important to control the syndrome that's caused by some of these tumors, such as the gastrin-secreting tumor of the pancreas. I changed this slide. This came and is in memory of Dr. Steve Qualman, a pathologist, pediatric pathologist at Ohio State, who gave me this slide. And if you know neuroanatomy, it almost looks like a cell body, a nerve cell body. And you almost expect to see dendrites on the end. But those little Y's in there are for the very simplistic cartoon of the somatostatin receptor. and it's a very specific receptor, and based on the receptor and the high population of this receptor subtype 2 has given us a great deal of therapeutic options, as we will hear through the day, and as many of you know already. This cell and its tumors give rise to these, this cell can give rise to these tumors. And you can see many of them on there and listed on the sheet. Clearly, I put carcinoid in the lower left corner because small cell is also neuroendocrine, maybe a muted neuroendocrine cell that we know about. And in fact, many of the neuroendocrine tumor or carcinoids of the lung have a little more active behavior in our experience. But to say it another way, and you can see many that you recognize, including carcinoid, we'll look at that up close, but also the pediatric population has always had neuroblastoma. Dr. Sue Odorizio is now showing that neuroendocrine tumors run as high in incidence and prevalence as neuroblastoma in children and adolescents. And we'll come to that again. It was for the terminology from Oberndorfer in 1907, and he coined the term carcinoida, which means cancer-like. And for 100 years or so, it was always known as carcinoid. And all neuroendocrine tumors became lumped, if you will, or vice versa. All carcinoids really are part of the neuroendocrine tumor system. But it was an unhelpful system in a way, or a name, as we learned from Dr. Singh, simply because it didn't break it down, if you will. But in some respects, it may not be so bad, because it really does, in a way, define a population, a rather homogeneous population of tumor pathology. And we heard that as well, and we'll review that briefly. But so I think the term we live with, and now we're seeing how important it is to have a classification and a predictor, perhaps, of behavior. This is a slide from Arthur Vinnick that I've changed a little bit, because the pulmonary carcinoids are not really listed. We always hear of the gastroenteropancreatic neuroendocrine tumors, PNETs, and we know the midguts. But the pulmonary carcinoids are very much a part of the whole system. And we have to honor them and acknowledge them. And in fact, they can make up, and they're unfortunately not totally put together in terms of the actual incidence, because that SEER data is slightly distinct when you talk about pancreatic neuroendocrine tumors or the incidence of midgut carcinoids. And they're kind of always slid away. In actual fact, this is the most common neuroendocrine tumor in children and in adolescents. And that work will be coming out shortly by Dr. Sue Odorizio. But you can see, and this slide is very nice because I've changed it enough to let you know now we recognize an incidence of 38.4 cases per million. And half of those are, 55%, are the carcinoids, mostly of the intestinal, the midgut area. And then the 17, 15, 9, 2, and 1 all represent neuroendocrine tumors of the pancreas. So you can see that there's a high incidence as well of the, but in the big picture, 55%, 72% are from the whole intestinal tract, 55% are carcinoids of the small bowel, the midgut. And then the other neuroendocrine tumors are comprised of the pancreas mostly, and the foregut stomach, and we'll break that out. So carcinoid tumors were described, as you know. The prevalence now is estimated to be about 104,000. That's how many cases there are at any given moment in the United States. The estimated incidence is probably 11,000, of which over half of those are going to be of the gastrointestinal tract, mostly of the midgut origin. What are the nature of the neuroendocrine tumors? They are derived from neurocrest or neurocrest origin. They rise, and some argue that. Some say we should just say neuroendocrine, and I think that's more appropriate, neuroendocrine origin. They arise primarily in the gut, as we know, and the pancreas, and the most prominent ones are gastronoma and insulinoma of the pancreas. But one thing to remember is these are cells that normally exist. they're not autonomous. They're not thoughtless tumors. They do feed back. For instance, insulinoma is one of the harder diagnoses to make because they behave appropriately. When your sugar goes down, and your insulin will respond normally to go down. In an insulinoma, it's the inappropriate release of insulin when your blood sugar goes down. You don't want insulin around when you have low blood sugar. But the point is they're not autonomous. They will behave. They will behave the way they're supposed to behave in a classic feedback system. And in many cases, when we do have hormone markers in the blood from these tumors, a lot of times they'll actually be episodic and not always sustained. And they predilect to the liver and portal vein, and I'll share that once, my Matou slide in a second with you. And they're regulated, as we all know, by a very redundant system of somatostatin receptors, and in this case the predominant system is somatostatin receptor subtype 2. There are the other receptors that are on them as well, but 2 is the one that has been so exploited with the Octria scan and the therapy we heard about with Y90 and lutetium being done widely in Europe and not yet available either in the United States. Here's my Matou's drawing, and I've now added the lung. But if you look at the system on your handout, and you'll see that I drew the portal vein in red instead of blue. And in classic anatomy, red is always the oxygenated blood as an artery. But in the case of the portal system, it's quite unique because it takes blood, it takes tissue or elements from cells that need to be detoxified in the liver and carries it to the liver. So if you can imagine a tumor in the ileum shedding cells, and the portal vein, the superior mesenteric vein, taking those cells directly to the liver. And the same obtains for the pancreas. The rest of the portal vein is formed by the splenic vein, which acts as an artery to take these cells for detoxification, and they set up shop in the liver. Now, the foreguts are a little bit different. Their behavior isn't quite the same as a portal system directly to the liver. Rather, they tend to go downward in a gravity type of motion and probably hematogenous spread by way of the hepatic arteries to the liver. But they can also affect the involvement in the liver as well. So that's probably why, in many cases, many of the tumors of the midgut, perhaps 60%, at the time of surgery are found to have metastasis at surgery in the liver. It's really no surprise because I think the anatomy explains why it happens so rapidly and prolonged situation until the diagnosis is made. And many times in the midgut, as you know, it's an obstructive situation rather than a very obvious diagnosis. Well, the neuroendocrine tumors then, as we know, are 50 to 60% are carcinoids, and they're divided into foregut, midgut, and hindgut. And the foregut is divided, or is the classification is the lung, the stomach, proximal duodenum, which is right after the stomach. Believe the ovary and thymus and pancreas are involved as well in the foregut classification. The midgut includes the jejunum and ileum, the most prominent area and the most active of the neuroendocrine tumors. The colon and just beyond the appendix, the cecal area. And then the hindgut is the rectum for the most part. Pancreatic neuroendocrine tumors, only 40% are functional. 60% are non-functional. So the 40% that are functional are helpful because we can measure those in the blood with very specific radioimmunoassays, and that can be very helpful in the diagnosis. For instance, gastrin in gastrinoma and the inappropriate release of insulin and glucose, or insulin with glucose, has helped us make the diagnosis of insulinomas biochemically. And those are the others that are named: the very rare vasoactive intestinal peptide, glucagon-secreting tumors, somatostatin-secreting tumors. There are somatostatin-secreting tumors, and you can use octreotide or lanreotide to help treat them. You're inhibiting the inhibitor in that case as they make more and more somatostatin. 60%, however, are non-functional in the pancreas, and that makes for difficulty as well, on the one hand, because the other form of pancreatic neuroendocrine tumor, or pancreatic cancers, are the adenose cancers, which are very virulent when they're discovered, and the neuroendocrine tumor, on the other hand, as we are hearing, is for the most part more indolent. The biology of carcinoid tumors, they have reactions. There's a neuron-specific analase, which is a stain that was originally used, and the slide I showed you from Dr. Qualman was a neuron-specific analase. It's the granules inside the neuroendocrine cells now that are giving them their essence, if you will, and it's no longer the morphology. It's the staining with chromogranin A, as you see on the slide. It's the staining with synaptophysin. These are the little granules that exist inside the neuroendocrine cells and their respective tumors that give them the identity that these are neuroendocrine tumors. And we've learned so much from carcinoids, these cancer-like tumors, because we've learned about hormones we didn't even know we had until people who were affected presented with syndromes, such as corticotropin-releasing hormone, which we now know comes from above the pituitary, and it was identified in a patient who had a pancreatic carcinoid, and it was making enormous amounts of that, and the patient presented with too much steroid or steroid excess called Cushing's. Growth hormone-releasing factor, acromegaly, the giants. This is a hormone that releases the hormone that causes the growth from IGF-1, and that was discovered in a carcinoid tumor as well. Now, this is the classification of who that we heard about from Dr. Singh, and just to repeat it again, but to show you that the vast majority, as Dr. Singh alluded to, are type 1 and the well-differentiated neuroendocrine tumors and the well-differentiated neuroendocrine carcinomas. And the two things to remember are they're both well-differentiated. And then the third is the poorly defined one, and these are the small cell, and these have a higher proliferation index, a higher Ki-67, if you will. But the vast majority of these tumors that give them their indolent terminology is that term well differentiated. It means it looks a whole lot like normal cells. That's what that well-differentiated means, versus poorly differentiated, which means it's becoming foreign. We don't recognize it. It's morphed and is more aggressive. And the foregut tumors, in our experience, tend to be a grade 2-3 or a type 2-3. In other words, many of these are the small cell type. And I think it's the garden that they live in that creates the type of behavior of the cell. And this is just for your own edification, but this is the work from Solcia. When they put together the 2000 World Health Organization classification that ENETS has, European Neuroendocrine Tumor Society, has nicely modified and put a grading system and a lymph node classification system in. This was the work that they came together initially to define the well-differentiated terms. And as you can see, every one of the common GEP tumors, gastroenteropancreatic tumors, all have synaptophysin staining and chromogranin A staining. And then the other stains can also be found in them. The one we are very interested in biochemically, and we've heard a little bit about, was serotonin. But serotonin is not in all GEP tumors. And so we have to be very careful and not surprised if the marker is not high. And now we'll go to that. So to begin some of the markers, we'll first look at the box that we'll be so sick of by the end of the day. But this is our schema, and over in the lower left corner is the tissue diagnosis and the peptide radioimmunoassays. And it's very interesting that if we didn't have the isotope I-125, iodine-125, we probably wouldn't have had the discovery of the radioimmunoassay by Yalow and Burson. Because these hormones exist in very small quantities in the blood. You don't need a pound of this to roll around. You just need small amounts. And so to be able to detect these, you have to have a very sensitive, and this is one thing that Dr. Ardil has pioneered over the years as well, and we'll be hearing from her this afternoon in terms of how these assays, how we come to these assays, namely by very exquisite use of a very low gamma radiation in the form of iodine-125 in the assay. So the Ki-67 tissue staining, one slide from Dr. Singh was, what is my Ki-67? And that causes a great deal of consternation in many, many, many patients that I see. But there's a caveat that I want to share with you as I look at that, as I look at Ki-67 values that come. At the University of Iowa, we use the MIB1, which is identical. It's just a different antibody to the Ki-67. It is considered a cellular proliferation marker. It's associated with cellular proliferation, and the proliferation index refers to the percent of cells positive in a tumor section. I'll just move on to that one. This is a slide of a tissue with a rather high index, and you can see the dark brown nuclei staining very positively there, and that's what it looks like. And they count so many high-powered fields in so many cells. Some use 1,000 cells they count. Others, and that's a very careful count. Others use 3 slides with at high power, reading 400 cells each, and they'll come up with a percent. And that's the nuclear staining that you can all see from there. Now, if it's positive, it may assist in planning therapy. High indexes, as we heard about from Dr. Singh, may justify more aggressive therapy. The limitations is that the percent may vary from tumor to tumor, slice to slice, and it's not standardized. And here's my favorite. It could be a pepperoni stick or a sausage stick. But think about a biopsy, which is through a needle, a core biopsy, and you can see that it's an elongate piece of tissue that's cylindrical. And if you cut it on one end, you get a certain amount of fat modeling. In this case, you would get a certain number of cells that may or may not be highly positive for Ki-67, versus the back end of the sausage, which has less modeling in it. So this becomes a very important factor when tissue is passed around. Many centers in the United States want to reclassify. The comprehensive cancer centers in the United States, NCI designated, ask for reclassification of tumor. By the time the primary tumor is passed around in the form of paraffin blocks and cut, one answer from a year ago may not be the same finding with the Ki-67 after several sections of it have been done. So you have to be very, very careful when you hear your number what that really, really means. It can be very helpful, but usually the course of the tumor behaves in the way that the Ki-67 may be suggesting, but it isn't always the case. And in fact, in the same tumor, you will have different Ki-67 proliferations. What is the sensitivity of the various tumor markers? I think that the blood markers come earlier than even the Octria scan, which is sometimes earlier than the CT scans. And I think, unfortunately, the CT and the MR are the least sensitive, but they are the gold standard as we use the medical oncology criteria of RECIST criteria, which is very CT, MR driven in terms of size growth. That has to be our gold standard of recognition. But as Richard Baum has been saying, and said it, I think, in Winnipeg, he said, desist from RECIST. And that sounds very clever, and it's not going to happen, I don't think, if we're going to be able to do, exercise therapeutic decisions and to do the proper clinical trial studies that we need. But the markers are very helpful. We find one particularly, pancreastatin, that actually says things are going to change in the liver probably 3 months before the CT starts to change. So I think the markers can be very helpful, and we have to be very careful with how you interpret them, and you also need to be careful of the labs that they're drawn and making sure they're the same labs. We'll speak to that, but markers can be very helpful. Some are more predictive than others, and I think Dr. Ardil alludes to some of her spectacular studies with Neurokinin A, one of the markers of the midgut, and other tumors perhaps, and pancreastatin, which we've also completed recently. Most of the markers are biologically active in our bodies. Again, tumors about 50% of the time will make too much of a good thing, and serotonin is the biggest culprit in the midgut, and octreotide should always be used when tumors are clinically active, period. Because you have about a 92% chance that the tumors are going to have somatostatin receptor subtype 2, and octreotide has a predominant affinity for SST2. Now again, just to show you the syndromes and the hormones, that's carcinoid on the top. There's the pancreatic tumor in insulinoma. There's pancreatic polypeptideoma of the pancreas. Gastrinoma, as you can see, the hormone that wins from the tumor is named an OMA. OMA. So if it's a gastrin excess tumor, it's a gastrinoma. But it also can cause serious side effects because the hormone is very important in the body. So the syndromes are derived from too much of the good hormone being secreted. And in the case of insulinoma, it's not totally a syndrome. It's a profound symptom with a biochemically low glucose and the subsequent sequelae of low glucose levels in the blood for long periods of time or even a short period of time. Now, the foregut includes, as I told you, the bronchus, the thymus, the stomach. It has a low concentration of serotonin. There have been several papers, though, that do mark that serotonin can be present in many. The other hormone we find sometimes predominates is substance P, which is also can cause flushing, vasodilatation. And in this case, 5-HIA is really not very helpful if your serotonin is not elevated. Because as we learned today, serotonin gives 5-HIA is the breakdown product of serotonin with an enzyme. And the thing about foregut carcinoids is they tend sometimes, we have several that have it to the eye. It can go to the back of the eye, it can go to the breast, and it can go to the bone. So the foreguts kind of travel in a different direction before sometimes going to the liver. The midgut carcinoids include, as we note, they have very high serotonin levels, and in this case, serotonin is very helpful and does help to make up I call it carcinoid complex, because the syndrome has an implication. If you go back in a strict way to the original articles in the 40s, it talked about very severe right-hearted valve disease from the pounding of serotonin that goes straight up to the right valve, the tricuspid valve, and the pulmonary valve. We're seeing less and less of that now, thankfully, and it's due mostly in part, and I think Mayo Clinic has finally agreed, it's due to the fact that in '87 we started getting sandostatin and we were treating people, and I think that's why now we're seeing less of it, thankfully. But serotonin is a very good marker for the midgut carcinoids. But I'll say it again, it's very sensitive, but it's very labile. So if you have a grain of tumor or a BB or a marble, your blood level of serotonin may be just as erratic and high as a golf ball's full of serotonin. So you have to be very careful in how much you hang your hat on a serotonin level. The hindgut carcinoid rarely has serotonin, but it does, like the foregut, have chromogranin A. So in two instances, chromogranin A may be a very good marker for following the foregut lung tumors and the hindgut tumors. And those are, they rarely metastasize, but they're they're clinically silent and they're aggressive. And that's because chromogranin A is a prohormone. It doesn't have a lot of biologic activity. I think its job is to become pancreastatin in our blood. It's a breakdown product of chromogranin A, namely pancreastatin. And that, it has biologic activity. It can cause hyperglycemia, but it also tells you how sophisticated the tumor activity is in the liver. Again, just to be redundant, serotonin in carcinoids, midgut predominates serotonin, foreguts not so much, and the hindguts have very little. Now, one word about the 5-HIA, 5-hydroxyindoleacetic acid. It's very helpful in mudgut carcinoids, as you've heard, in our experience. And if you go back and look at all the technologies in chemistry on 5-HIA measurements, where they used a color change, now they're more sophisticated in the measurement with high-pressure liquid chromatography instrumentation. In our experience, it takes 20% liver tumor burden by Doppler ultrasound before you have meaningful changes of serotonin or of 5-HIAA in the urine. So I don't think it's the first test of choice if you suspect a carcinoid to be measuring 5-HIAA unless your CT scan shows that there is involvement already of the liver. Now, a brief word about the chromogranins. D.T. O'Connor described this in San Diego several years ago, and these are the proteins that give the cell their identity. Those are the little granules when you stain them, and these are very, very good markers for neuroendocrine tumors. And Dr. Oberg will probably hopefully I'll have a comment, because he helped forge the Chromogranin A story in Europe. And in Europe, it's extremely good, because the Chromogranin A, for the most part, the assays have been standardized. In the United States, we have 5 different laboratories, and one of them will come back, the patient says, my Chromogranin A is 5, and it used to be 300. Well, the bottom line was that the assay that they measured it on, they have a different unit. So 5 is the upper limit of normal in that one assay, and it gives just a false impression. But it's a precursor only. It does not have biologic function that we're aware of. It's broken off, and it becomes an active fragment called pancreastatin. Just a little bit more about Chromogranin A. You can see it on your notes. It is cleared by the prohormone convertase 1, which then makes it into pancreastatin. And CGA is probably a good marker for tumor burden. And like I said, it can be very helpful for the hindgut carcinoids as well as the foregut carcinoids. But a caveat that we heard this morning as well, even low-dose short-term proton pump inhibitors for longer than 3 weeks can change. Prilosec, you have them, your proton pump inhibitors. Nexium, we have people who have been on it 8 years. And what happens there is a mechanism that's very straightforward. When you have that much acid inhibition, the bottom part of your stomach starts to make a lot of the hormone gastrin. And gastrin causes growth of stomach lining. And what that does is stimulate the chromogranin A from the little cells that make chromogranin A in the stomach. And so people will come in with very high levels. I've seen very high levels with chromogranin A. And the concern is this patient got a carcinoid tumor? And no, what they have is an industrial dose of proton pump inhibitors that should have been taken off weeks and months ago. And that's a false high. You also see it with with renal disease and with hypertension. So another assay, another result you need to be very careful about when you interpret. My parting pearls, stay with the same lab. There are 5 in the United States. It's very helpful when you know you have a neuroendocrine tumor. It is not helpful when you don't know you have a neuroendocrine tumor. It's just like the CEA, carcinoembryonic antigen, for colon cancer. Once you've had the colon cancer, it's a very good marker for following recurrence. But in this case, if you don't know you have the tumor, CGA is not the first one to reach for in the blood. And I'll pass over neuron-specific enolase. It's really too non-specific, and it's not used. There are labs that still measure NSE, but I think it's just too non-specific. Just a word on neurokinin A, and hopefully Dr. Ardill will speak to her assay, which is exquisite and which has very important bearing in terms of helping with therapeutic management and how aggressive to be. But it should be considered another tumor substance. It's a vasoactive substance, and it tends to come from the midgut carcinoids, as does serotonin and does substance P, both from the midgut. So those are a battery of tests that you can do when you're trying to find a primary. One of the things that we need to keep in mind is that the primary midgut is not easy to find. And even in the best hands, the gallium-68, even Richard Baum says, they can find about 68% of the midgut carcinoids when he uses that highly sophisticated gallium-68 PET octreoscan. And there's a reason for it. And the reason is that, ironically, the SST2 expression, the number of cells, the number of receptors, the number of locks on that tumor of the midgut is not that high. And you can miss a primary. And you'll find it in the liver. And it'll light up in the liver 100% of the time, but it may not. So when you're looking at your marker batteries and people have symptoms, you say, oh, yes, that's got to be a midgut. But then the next step is to get your team surgeon to say, would you mind exploring this patient? And we'll learn a little bit about that, and at least our view, on the next talk. But that's not an easy algorithm of decision making to convince a surgeon when he can't see it by CT scan, or he can't find it by octreoscan or PET scan, to go in there and try and get it, where the odds are very high that it's in the midgut. And that creates a problem, because if you don't have the primary, it does change your life curve. Pancreastatin is the breakdown product of chromogranin A. It's by molecular weight 100 times more sensitive than chromogranin. And we won't go into the kinetics except to say pancreastatin is measured in very small amounts in the blood. Chromogranin A is measured in very high amounts of units in the blood. One is 10 to the minus 9th grams, the other is 10 to the minus 12th. So it's a very small amounts. And that's why we think it's such an early detection. There are two assays in the United States, one in California and the other in Ohio State University, a university reference lab that I set up in 1997 for them, and we calibrated against each other. But in Europe, I think Dr. Ardill's is the premier pancreastatin assay, and I hope the Canadians can avail themselves to that assay. We think we're seeing the same piece of the chromogranin A. This is the paper that's coming out in January, and those are the two. These are split samples, one sent to Ohio State University, the other sent to Inner Science Institute, and the difference is about 5-fold. So pancreastatin sees chromogranin A at Ohio State University, and so it's 5 times higher levels than it is at the Inner Science labs, which only sees pancreastatin. But the trend is the same, and the information is the same. Now, this is one patient that we had, and you can see on the bottom that there was 5-HIA and chromogranin A, and this was done over several years. And you can just see what happens. The pancreastatin was telling the story. When there was massive intervention with that vertical line, it dropped, there was improvement, and then the pancreastatin started to rise, and the CT scans then showed progression in the liver. Whereas we had very little support from the chromogranin A and the 5-HIA. So we believe that it's a very, very good marker for early liver tumor activity. It doesn't mean you panic because you're way in front of the curve when it starts to jump. How much does it have to jump? We think at least 10-fold, maybe 20-fold before you'll start to see changes. And I'm just going to go right through that. But it also has a very predictive, perhaps, role in the few papers that have been published in the United States. You can see before and after an intervention of, let's say, hepatic embolization, bland, or with chemo. If you measure a pancreastatin level before versus after the procedure, a 20% reduction of pancreastatin may well bode for stability. And that's an important point, and it may show therapeutic implications. Dr. Ardill also has suggested that as well with a trial of sandostatin to see if pancreastatin drops and what happens prospectively or retrospectively to those patients. Please, I hope Dr. Ardill will make a comment on that. Finally, we're back to the box again, and we're going to talk about two assays that you don't think so much about, and it's the actual somatostatin and lanreotide assays. And the reason we think they're very important to have a blood level is because there is data now that more is better. For a while it was thought that if you just stayed with the FDA recommendations of 30 every 4 weeks, we heard a little witness this morning, and I was excited to hear that, because the medical oncologists were the first to break out of the FDA box. And instead of saying 30 milligrams of long-acting repeatable every 28 days, I was seeing folks that were on 60 milligrams, 30 every 2 weeks. And there was just no hesitation. And they were coming, the medical oncologists were treating with more, because they knew that the more you gave, oftentimes the better the control of the symptoms. And there's all kinds of caveats with that, but that's what happened. So blood levels can be very helpful, and we have a series of studies with colleagues at LSU, Dr. Woldering, Dr. Vinnick, Dr. Go, that looked at the blood levels of octreotide. And what I want to share with you is the similarity. Over on the left is a slightly modified octreotide. That's how it looks. That's how it was made by pharmacy. It's called a congener. You can't call it an analog, because they made these moieties so that they're resistant to breakdown. We heard that somatostatin lasts only a minute in the blood. These pharmacy-designed, Sandoz-designed, Ipsen-designed drugs are long-lasting, and that's what's given them therapeutic benefit. Over to the right, it looks just like it. It looks like you turn it upside down. It looks the same, and that's the lanreotide moiety on the right side. And those are the two structures that many of folks use in the United States and Europe. Now, sandostatin was approved by the FDA, as you heard today, in 1989. Two forms are short-acting. One was termed, which you give the short-acting for rescue. That usually has to be given 3 times a day. And the long-acting repeatable is the one that you give every 3 or 4 weeks. We find that by moving the same dose closer together, you get a higher blood level, and we've been successful with that. The absorption is about 65 to 70%. So when you take a shot in the muscle, your absorption is not 100%. It's about 65 to 70%. And it has a peak and a trough action, and I'll show you that in a moment. And the doses that we have in the United States are 10, 20, and 30 milligrams. There was a preparation many years ago that was, and Dr. Oberg championed the higher dose, and it's a more powerful action form of sandostatin, but it didn't come to clinical use. Lanreotide is approved in the United States for the treatment of the tumor in the pituitary that causes acromegaly. But it's not yet approved for, and is used out of indication, however, for neuroendocrine tumors, but is not approved as yet by the FDA. The form that we have in the United States is called deep sub-Q. So it doesn't go into the muscle, but it goes deep into below the skin into the dermis. Similar absorption as sandostatin, they have the very same absorption rate, but which makes lanreotide very appealing is this square wave phenomenon. And the two doses that are going to be available in the United States are the 90 milligram, which corresponds to 20 milligrams of sandostatin, and the 120 milligram of somatulin, which corresponds to the 30 milligram dose of sandostatin. And you can get both of these assays measured at Inner Science Institute. We've set these assays up, and that's the schematic, and I think you have it there. When you take the sub-Q insulin, it works the same when you take rescue every time. It peaks in 30 minutes, it plateaus in an hour, and half of it's gone. That's on the far left side. When you take the IM injection of LAR, long-acting repeatable, look what happens. You dump a bunch of octreotide for about 24 hours, then it flattens out, then the level goes up at about 8 to 10 days. And that's what you have to remember. It takes 3 injections monthly without any rescue to raise your blood level of sandostatin. Now, in the red is the lanreotide. And the lanreotide, you give a shot and it goes straight up and it stays in a very steady state. And probably it is going to be much more ease of use than what we've recommended for some patients that need very high levels, and that is the subcutaneous insulin pump that gives sandostatin. We have 90 patients in the United States that take the pump. They do extremely well with it, but it's an expensive item and insurances don't always carry it. So I do believe lanreotide is going to be very advantageous. You can take it at home, and it's a deep sub-Q. But those are the two preparations. Those are the two games. They're the first and foremost therapeutic option that we're going to be talking about in the next talk. But this is approved for sandostatin for the indications of secretory diarrhea of carcinoid and or VIP and or acromegaly. So I'm going to stop there, and thank you very much for your attention. Peace.